Good afternoon. I'm Dan Salmon, and I am pleased to join you all today. I am with Johns Hopkins School of Public Health, where I'm at an Institute for Vaccine Safety. I need to disclose that I am on an advisory board for Janssen, and I also receive grant funding from. So today's learning objectives are as follows. First, I'm going to define vaccine hesitancy, and then I'm going to talk a little bit about the predictors of vaccine hesitancy, a little bit globally, but more so nationally, and what impact it's had on vaccine uptake. I'm going to look at local trends and the clustering of vaccine hesitancy and how that impacts vaccine preventable diseases, including COVID. I'm going to talk about different counseling strategies to assess hesitancy, which can be used in community pharmacies, and then different approaches and strategies to mitigate hesitancy in the community through pharmacies. So let me just start by saying this. Vaccine hesitancy was a big issue prior to COVID, and it's now an issue that's all over the news. But this story is from 2019, before the COVID pandemic was widely recognized. And the World Health Organization determined that vaccine hesitancy was a top 10 global health threat at that time. So, a general definition for vaccine hesitancy, and this comes from the World Health Organization SAGE Working Group, but vaccine hesitancy refers to the delay in the acceptance or refusal of vaccines despite availability and vaccine services. But the focus here is on this definition, delay in the acceptance or refusal. So it's a behavior. With that, it recognizes this definition, the complexity and the context specificity of vaccine hesitancy and how it can change over time and between different places and for maybe one vaccine and another. And lastly, it's influenced by factors including complacency, convenience, and confidence. This is a widely used definition. And here's a figure from a report at the time where it highlights this continuum of vaccine hesitancy. But again, in the context of people who accept some, delay some, or refuse vaccine. So this is a definition which is based on behavior. But in fact, a more nuanced definition of vaccine hesitancy would recognize that there are concerns about the decision to vaccinate oneself or one's children, that often this is a balancing of the perceived need for vaccination versus the perceived risks and benefits of that vaccine. And it can include people that refuse some vaccines, people that refuse all vaccines, people that delay vaccines and use an alternative vaccine schedule, but ultimately get vaccinated. But even people that accept all vaccines may do so, but remain concerned. And this is still people that are hesitant, even if at the time they're vaccinated. A lot of attention, if those that remember going back to 2015, was a measles outbreak that occurred in Disneyland. And as I'll show you, the outbreak itself was not really unusual. But I think what was most unusual, it was bigger than most, but what was most unusual that it was in Disneyland. It was a place that people think about for taking children to be safe and to have fun. It was a fairly large outbreak for measles, about 131 confirmed cases, and it got exported to other states, other countries, including Quebec and Mexico. If you look at the recent epidemiology of measles in the US, before there was a vaccine, pretty much every child would get measles and millions of cases would get reported every year. In 1963, the first measles containing vaccine was introduced. And following introduction of two measles elimination efforts, we saw a real decrease in cases down to 1.3 per million people vaccinated. We then saw a resurgence of measles in 89 through 92, and this was largely due to poor immunization coverage among minority immigrant populations. So even though vaccine coverage at the state level and the national level was very high, we saw there were still outbreaks because of local low coverage. And this also led to the introduction of a second dose of measles containing vaccine in 1989. By 2000, measles was declared eliminated in the United States. And what this means was there was no indigenous transmission of measles at most points in time. However, as I mentioned with the Disneyland outbreaks, there were outbreaks. And they tended to be importations from other countries that had a lot of measles, often Europe, and it would come into a community that had low vaccine uptake, that had a lot of refusal, and there were many outbreaks like this. In 2019, there were 1,282 cases from 31 states, and this was the greatest number since 1992, which I mentioned that last major outbreak. More than 75% were linked to New York outbreaks, and this was among a religious community that had been targeted by anti-vaccine groups. The majority of cases were linked to unvaccinated children, and in that year, right before we saw COVID, almost lost our elimination status. But when you look at measles, it's kind of the canary in the coal mine, right? Because it's the perfect disease to study and to understand vaccine hesitancy. It's a very infectious disease. Two vaccines are highly effective. Probably 97% of children will be protected, usually lifelong protection. However, it's circulating all over the world. And because of international travel, it gets imported. So it really just has the potential for a fire. When you have a community with low coverage and a lot of hesitancy, and measles comes in first. And what you'll see is that there is a lot of geographical and social clustering of vaccine refusal. These are what these numbers of cases look like over this time period. And it gives you a sense of, the size of each of these outbreaks. When looking at what we know about these cases, and here you're looking at the cumulative epidemic curve of 18 measles outbreaks over this 15-year period. And you look at the role of the unvaccinated that were dark versus unknown vaccine status versus the vaccinated that were light. And you see that in most of these outbreaks, they started among the unvaccinated and then sometimes picked off these vaccinated, which are, no vaccine is 100% effective. So when there's measles circulating, it will in fact find those vaccine failures. This is a map of Washington kindergarten immunization exemption rates. And the data is old, but the point is here. And what you see is, and it's by school district. And you see that while overall about 5% of kindergarten kids in Washington had an exemption, there were communities that had exemption rates as high as 20%. And this really exemplifies that clustering. A study we did in looking at Michigan and pertussis clusters and exemption clusters, the exemption clusters being in yellow, the pertussis clusters being these red dots. And you see that if you lived in an exemption cluster, you were about 3 times as likely to also be in a pertussis cluster. So what are the causes of vaccine hesitancy? One of them is that vaccines are often called a victim of their own success. And here you see the comparison of 20th century annual morbidity versus 2017 reported cases. And this is for the more traditional vaccine preventable diseases. And it really shows the remarkable power, success of vaccines. I mean, smallpox has been eradicated, polio will likely soon follow, and the incidence of most vaccine preventable diseases are down 95, 99%. This figure really depicts the situation, and it's a little bit complicated, but let me walk you through it. So, on the y-axis, we have incidence. And on the x-axis, we have time or maturity. And when there's no vaccine, this is time period 1, you have very high rates of disease. When a vaccine is introduced and vaccine coverage, the red line goes up. What we see, of course, is disease come down, which is the very point of a vaccine program. But as disease comes down, we also see reporting of adverse events. And this is a line in yellow. And just to be clear, these may be real adverse events caused by the vaccine or vaccine reactions, or they could be coincidentally related. And we'll talk about that more in a minute. But what we see in this time period 3 is the rates of adverse events is actually as high or about as high as the rates of disease. And this is really at a point where we're very vulnerable because public attention can easily shift from the risks of disease to the risks of vaccines. And when this happens, we see a loss of confidence, we see a drop in coverage, and when coverage comes down, disease comes back and we see outbreaks. We saw this, for example, the wholesale pertussis vaccine in the 1970s and 1980s, Japan, the United Kingdom, Sweden, many other countries. We saw this with measles, mumps, and rubella vaccines. Europe has had huge outbreaks of measles, largely because of vaccine hesitancy. Perhaps the good news is when you have an outbreak, like we saw in California, that can change public attention and it can shift then back to the risk of disease, resulting in a resumption in the confidence of the vaccine. This would be time period 4, and coverage comes back up. This again, coverage goes up, disease comes down, and this is the evolution of an immunization program. There's many examples of this. Now, if we hit eradication, as we did with smallpox, well, then we can stop vaccinating altogether. In many cases, we'll never eradicate the disease. So if you take measles, for example, we're likely to have measles for a very long time. And even if we were able to eliminate or eradicate measles, it would be such a terrible biological weapon that we would probably still need to vaccinate. So imagine a world in 50 years where there's no more measles, but we still had to vaccinate for measles, and what that would do to this figure. So here's that same table I showed before, but I included reports to the vaccine adverse event reporting system on the bottom here in 2017. Now, just to be clear, these are reports somebody made to a government database. I could get my child vaccinated for the flu vaccine, and then my dog could get hit by a car, and I could make that report to VAERS, and it would show up in these numbers. So this doesn't mean these are true adverse reactions, but it was enough to prompt somebody to make a report. And in fact, you see the reports to VAERS are getting close to the number of actual cases. And if you took pertussis out of here, it would actually be more. So one piece of this is having vaccine safety science that's proactive and timely. And we need to characterize safety problems in a really, really effective way that will be compelling and convincing to people. We can even look at history and get a good idea for what are the characteristics of vaccine safety scares. They tend to be for things that are recommended around infancy or another time when a lot of adverse health outcomes happen. And often the outcome of interest tends to look like it's increasing in incidence or recognition, poorly understood etiology, so it's easy to blame the vaccine, concerns to the public, and often advocacy groups. I mean, measles, mumps, and rubella vaccine and autism is a classic example of this. And the challenge is that good science takes time. And it takes time to get clear answers from science. In contrast, anecdote and sensationalism and bad science travel very quickly. It's difficult to change someone's mind once they've made up their mind. And this is because of many heuristics, including cognitive dissonance and affirmation bias. And what we really need to do is to inform views with science as they're being formed rather than trying to change people's minds. So let me give you an example on the autism issue. At this point, we have 16 methodologically sound studies that have looked at whether autism or autism spectrum disorder is associated with MMR vaccine or thimerosal in vaccines, or multiple vaccines given simultaneously. And all 16 of these studies find no associations between the vaccines and autism. However, about a quarter of the population still believes this. Now, this has led some to say, well, the science doesn't even matter. But in fact, if you look at when these issues first arose, for example, the MMR scare, when Andrew Wakefield published his paper in February of 1998, and then when these studies were done. And you see it took 18 months for the first study. It took a couple of years for the first study in the US. So there was this vacuum in time where you had a charismatic, well-credentialed physician traveling the world saying vaccines, MMR causes autism, and there was no science, no epidemiological evidence to refute it. In the case of thimerosal, this became an issue in July of 1999. And again, it took years, several years, before there was evidence, which ultimately showed very convincingly that the vaccines didn't cause autism. But it took too long. And in this time period, it allowed all these concerns to spread across the world and fester among parents. So part of the challenge is these coincidental temporal relationships. If you vaccinate a lot of young children, bad things will happen by chance alone. Just because these two things happen together doesn't mean one causes each other. In fact, this is a human fallacy to assume that after this, therefore, because of this. And before we had science, that made a lot of sense. If I saw my friend eat berries off a bush and then he threw up, I would assume they were probably poisonous and I shouldn't eat the berries. However, maybe he was going to throw up anyway. And we can't presume that because there's a temporal relationship, that there's a causal relationship. Certainly the exposure has to happen before the outcome, or it couldn't have caused it. But the question is, did it cause it? This is a paper that we published right before the 2009 H1N1 vaccine program. And we looked at a bunch of different outcomes and how many cases one would expect within a day or a week or 6 weeks after vaccination. And we published this in the Lancet simply to make the point that when we vaccinate a lot of people in a short amount of time, we can expect that these things will happen by chance alone shortly after the vaccine. On top of this, because if all these factors didn't make things hard enough, right, the vaccines being victims of their own success, knowing that we're going to have these temporal by chance relationships, there's all these different heuristics which make the risks of vaccines often seem bigger than they really are. For example, things that are voluntary seem less risky than things that are involuntary, like vaccines that are sometimes mandated. People feel like the risk is lower when they have individual control versus system control. So for example, if you ask people if they're better than the average driver, depending on the poll, somewhere 70, 80% will report that they're better than the average driver, which, of course, that can't be true. And if you look at the fear of flying, actually your risk is higher driving to the airport than flying on the plane. But people feel the risk higher on the plane because they give up that control. A preference for errors of omission versus errors of commission. Like somehow if my child got sick by the vaccine, an error of omission, not vaccinating my child, that would be better than my child getting sick from the vaccine, an error of commission. Now, in reality, the child just probably doesn't want to get sick and isn't looking to blame anybody. Vaccines being considered man-made versus natural, the risk being unpredictable, dreaded, exotic, all of these factors create a perception that the risk is bigger. And then on top of this, we have all these other contemporary factors. Trust in corporations and government is at a very low point. There's fear of the pharmaceutical industrial complex, a growing interest in natural products. I can remember a decade ago, Jenny McCarthy leading a march on the main headquarters for HHS in DC, the Hubert Humphrey building. And the signs they were carrying said, "Green our vaccines," which I don't even know what that means, but it sounds great. And certainly if I'm using green, detergents in my house, I should be using green vaccines for my children. We also see a change in the medical model. We see a big push for shared decision making, where a parent or a patient comes in and wants to talk about the issue and be a part of the decision. And there's lots of great things about shared decision making, but this is more difficult in the vaccine context. And that's in contrast to what used to be a very paternalistic approach. A parent came in, the doctor said, "Get these vaccines," and the parent did what they were told. And that's changing. At the same time, the clinician is asked to see more patients in less time, and patients and parents are getting all this misinformation from the media, from the internet, and are often coming in quite confused. Here's some fairly recent data on parental reports of vaccine concerns. We see 3/4 of parents are reporting concerns about vaccines. About a third are more serious concerns. How many vaccines are given at one visit or in the first 2 years of life? 30% that vaccine can cause learning disabilities like autism, and about a quarter of parents concerned about vaccine ingredients. This is a study we did years ago, looking at parents that did not vaccinate their children and claimed a non-medical exemption to a school immunization requirement compared to parents of vaccinated children. And these were elementary school children from 100 different schools in 4 states. And we found that parents of exempt children perceived the disease susceptibility to be lower, the severity of disease to be lower, the safety and efficacy of vaccines to be lower, and they were more likely to have low trust in healthcare providers and low trust in the government. If we look at parents, and this is actually true for adults as well, but they tend to fall into different categories. And this is using latent class or audience segmentation type approaches. But you have immunization advocates. You have parents that want to get vaccinated. They have a great relationship with their doctor. And there's a lot of parents like this. Typically it's about a third. You have another third that are called go along, get along. They're basically going to do whatever the doctor society wants them to do. They don't have a lot of information. They don't even want a lot of information. They're just going to go with the herd. You have cautious acceptors, and this is the group that may have concerns, but they do vaccinate. Then you have the fence sitters, and these are the ones that are really most important in terms of if they go over the fence, we're going to see big outbreaks. But if we work with them and they get vaccinated, we can really make a difference. They tend to have concerns. They tend to be knowledgeable, and they may vaccinate some or others. And they have, an okay, but not a great relationship with their doctors. And lastly, you have the refusers. Now, traditionally, this is a very small percent. Maybe 2% of parents in the US refuse all vaccines for their children. And there can be lots of reasons for this, from conspiracy theories to really widespread distrust to very small numbers that have very strong religious beliefs. What are the solutions? Well, I talked about vaccine science that needs to be proactive and timely, rigorous, relevant. It needs to be objective. It needs to have the appearance of objectivity. But we also need communications that are proactive and timely, that are evidence-based, that find commonality with the public, with parents. They need to be tailored to meet the needs of the patient or the parent, and I'll talk about that. And they need to come from credible sources. So let's think about vaccine confidence in the COVID era. With crisis can come opportunity, though it's certainly not assured. And COVID has offered this opportunity for vaccines and public health. I mean, the pandemic has caused global morbidity, mortality, and tremendous social and economic disruptions. We have very safe and very effective vaccines that in the US are widely available. And this affords the opportunity to really show the value of science, the value and power of vaccines. Here we see cases of COVID in the US and reoccurring waves, and Operation Warp Speed, who was a tremendous success, right? The goal, the objective was to assure that every American who wants a vaccine can have one. By delivering safe vaccines in 2021, January. This goal was met, and that's an amazing accomplishment. However, the goal was also short-sighted because simply having a vaccine available, sitting on a shelf, doesn't save a life. It doesn't curb a pandemic. We need to vaccinate people to have an impact on disease. So it's not enough just to have access. We need uptake. And hesitancy is a huge issue. To assume that if we build it, they will come may be a false assumption. I mean, it was true for polio vaccines a very long time ago. What do we see with the pandemic? You know, time and time again, politics impacting science and our response to the pandemic. And as a result, it undermined our response and the public's confidence in that response. As a result, we see people that don't believe COVID has had a big impact, that mortality was exaggerated and doctors were paid off to over-report COVID. Further distrust in the pharmaceutical industrial complex and this perception that the vaccine was rushed. So we really need to get this right. We really need to get these vaccines in the arms of people, of children. Here we see some very recent data. These are unpublished. At this point, this was a survey my group did, and we found that about 77% of the public had at least one dose. And this is consistent with CDC estimates. We see still a small number of people that want to get the vaccine as soon as possible, and they report access barriers as well, things like transportation, childcare. And then we have about 9% that are unlikely and 13% that are uncertain. For us to control this pandemic, we need to get coverage at a higher level. And as I've talked about, it needs to be homogeneous, needs to be across the country. We can't have low pockets socially, geographically with lower coverage. We're not going to be effective in controlling the pandemic. The most common sociodemic characteristics of the unvaccinated, they tend to be white, younger than 45 years of age. They tend to be without a bachelor's degree or less education, earning less than 85% a year, 85,000 a year, and they're most likely to be Republican or independent. So this is what the big pieces of our unvaccinated pie look like. Some of the common concerns among the unvaccinated, you know, speed of development is the biggest one. Potential for immediate or allergic reactions, concerns about ingredients, the fear that the vaccine will somehow change your DNA or affect fertility. So these are the most common. You know, this is what's out there, and this is what we need to address. When we look at childhood vaccines, these are data from Kaiser Family Foundation, and we see about half of children 12 to 17 are vaccinated. And we still have a very large percent, 15% wait and see. 4% who say they will very soon, 8% that don't know or refuse. So we have a lot of progress that can be made here. Another recent finding we had was that parents were less likely to get vaccinated than people who didn't have children, 2 to 17. And this was the case even after adjusting for age, right? So if you were a parent, you had an odds about 40% lower of being vaccinated than the non-parents. And the parents' vaccine status is highly correlated with whether or not the child gets vaccinated. which, isn't terribly surprising. So we have a lot of work to do here. There's a lot of progress that needs to get made, and even more so for pregnancy. 65% of pregnant women were not vaccinated. And you see, these are data from the Vaccine Safety Data Link. The number vaccinated is low, 14% prior to the pregnancy and 19% during the pregnancy. So these are a lot of pregnant women that are at increased risk of COVID morbidity and mortality. So let's take a minute and talk about how do you communicate the vaccine risks? Well, firstly, taking a presumptive approach, and I'll talk about what that means a bit more, is really, really important. And when I say a presumptive approach, I mean coming in and saying to the patient, okay, it's time to get your vaccine today, would be a presumptive approach. And for a vaccine that has a full approval, it's a standard of care, that's the default option we need to take. That's in comparison to, oh, you have a vaccine due today, would you like to get it? And that would be a participatory approach. There's really solid data from randomized controlled trials that if you teach clinicians to start with a presumptive approach, that it has a huge impact. So start presumptive. If it's a licensed recommended vaccine, this is what we do. We vaccinate. When you do have concerns, absent a one-on-one conversation, when you do have concerns, you want to really think about how you raise them. You want to establish empathy and trust, but you don't want to validate misinformation. And I'm going to talk more about this. So, for example, if you have a parent that's concerned about vaccine ingredients, you want to find a way to connect with that patient, and you want to find a common value. So you could say, I understand you want to make sure everything that goes in your child's body is safe. That's a common value. Certainly any clinician and every parent wants that. What you don't want to do is say, I understand why you're worried about vaccine ingredients. Because even if you go back and debunk that myth, simply by restating it, you'll actually reinforce it. There's a 5-step process which we teach, and I'll talk more about it. And we say start presumptive. And then when you have a concerned parent or patient, establish empathy and credibility, as I described to you, right? Don't reinforce the myth, but find a way to connect with a common value. Address the concern. Do it briefly. Pivot to the risk of disease, the value of getting the vaccine, and then give a strong personalized recommendation. I tell all my patients to get this vaccine. My own children are vaccinated. This is a really effective approach to take. We talk about this in a book that we recently published, and we talk about first how to talk to patients about vaccines. We cover the different diseases, the different vaccines, the recommendations, the contraindications, what the safety system looks like, and then we look at almost 50 vaccine safety issues, and we summarize the evidence. Does the vaccine cause this or not? And if it does, how frequently and among whom? We're getting ready to put this out on a pocket guide, and this will be updated with COVID information. And this allows decision support on a tablet, on a phone, and it allows us to update it practically in real time, and for the clinician to access it by any mobile device, even without internet connectivity. Another product we're developing, and this comes from work we did prior to the pandemic. This was a website called Moms Talk Shots, and it's an individually tailored website. So you can go to it from a smartphone, from a tablet, from a computer, and it starts by collecting survey data on the user, demographics, vaccine intentions, knowledge, attitudes, beliefs, trusted sources. And then based on that information, it tailors a message through videos, largely animation, that really meets the need of that patient and matches their demographics. So this is what it looked like, right? So the person who recognizes the value of vaccines and intends to vaccinate. This is the third. half of most parents. And for them, it simply reinforces the decision leading to vaccine uptake. For those that have concerns or knowledge deficits, it's a more detailed video, starting with a clinician establishing empathy and trust, that clinician's congruent on race or ethnicity, and then some animation. And we use animation because it's engaging, it's interesting, briefly addressing that concern, the most common being the burden of disease, serious side effects. This is around maternal and infant vaccines, ingredients, immunization schedule, pivoting to the risks, emphasizing the effectiveness of vaccination, and then a strong personalized recommendation by the same clinician, same race and ethnicity as the user. And I'll give you an example of what this looked like. And this was for a woman who was pregnant and had concerns about side effects.
Hello, I'm Dr. Laura Riley, and I'm the Vice Chair of Obstetrics at Massachusetts General Hospital, and I'm a mother. I understand why you are concerned about everything that you put into your body when you're pregnant, because you want to have a healthy baby. And some women are concerned about, vaccines and what that could mean for them. And there's so much information on the internet that it's sometimes hard to tell the difference between what's true and what's not true. I have a few facts to share with you about the flu shot. I strongly recommend that my friends, my family, and all of my patients get the flu shot.
Pregnant women who have the flu are more likely to experience severe, life-threatening illness or death than non-pregnant women. And if it's flu season and you're pregnant and the vaccine is available, then you should definitely get the flu shot, because getting the flu during pregnancy can affect your baby's growth and also increase your chances of having a premature baby. Pregnant women who get the flu shot rarely have any side effects and will share protective antibodies with their unborn baby. Babies under 2 are the most likely to have severe complications from the flu. They can get very sick. There are between 12 and 30 infant deaths due to the flu in the United States each year. This can be so easily prevented with the flu shot. Newborns can't get a flu shot until they're at least 6 months old. The protection you give your baby is all they have for the first few months of life. It's really a great gift. It's also a good idea for your friends and family members who will hold and care for your baby, like dad and grandma, to get a flu shot too, so they don't get your baby sick. This is called cocooning. You may have heard people say that they got the flu from a flu shot. This is one of the biggest myths about the flu shot. And it is, as the Mythbusters would say, busted. Flu shots contain an inactivated virus. You can't get the flu from it, but it doesn't prevent the common cold. So remember, it's a myth. The vaccine does not give you the flu. And if you're wondering about side effects, the truth is that if you have any side effect at all, it'll probably be a sore arm, or you may feel achy after getting the shot. That's a sign that your immune system is working. Better for you and your baby than the flu. About 2 in a million people will have a serious reaction, which is a very, very small chance. But in 2015, over 5 million people got the flu. In an average year, over 36,000 people will die from the flu. Get your flu shot to protect yourself and your baby.
I strongly encourage you to get the flu shot when your doctor recommends it, and please visit us online for more information.
Vaccines save lives. Visit the Johns Hopkins Institute.
So that gives you an example of what this looked like, right? But it's tailored, in this case, would be an African-American pregnant woman who was worried about serious side effects. So we evaluated this through a randomized controlled trial of about 2,000 pregnant women. They were recruited from obstetric practices, making sure that they were sociodemographically diverse, but also diverse in terms of their vaccine attitudes and beliefs. We looked at self-reported information needs pre and post the videos, self-reported usability, vaccine knowledge, attitudes, and beliefs, and maternal vaccine uptake. What we found was, in fact, that it increased influenza vaccine uptake among pregnant women, those who were uncertain or not going to get the flu vaccine. It increased influenza vaccine uptake among their family and friends, for cocooning. And we had a sustained sustained impact on their attitudes and beliefs, including reducing concerns about infant vaccines by about 70%. We're in the process of developing a Let's Talk COVID vaccine website. We plan on launching this in January of 2022. And it's similar in that it audience segments people. It's available English, Spanish, and there's a French Canadian version focused on adults, children, and pregnant women. And likewise, we segment for those that are likely to get the vaccine versus those that have concerns. These are the initial concerns that we're addressing. And we've added a piece to this, which we call the emotional lived experience. So this would be somebody's personal story. I didn't vaccinate my young, healthy adolescent child because I was worried about how fast the vaccine was developed. And then my child got COVID, and this is what happened. So to bring that emotional, personal experience into the messaging. So how do we find a path forward? Well, I think we need to recognize that there's commonality here. Most people are not anti-vaccine, but many people have concerns. We need very high coverage, homogeneously, maybe indefinitely, and we're not going to get there by yelling and name calling. That leads to conflict and further polarization. We need public medicine and public health to share their common values and desire to protect the health of the individuals and the population. And it's through that approach and tools to facilitate those conversations that we're most likely to get past vaccine hesitancy and the problems that they're causing us.